Have you been told your vitamin D levels are healthy or low based on lab testing? What if I told you there's a big chance that interpretation is wrong? What if I told you that supplementing with vitamin D3 based on these tests can be problematic? And what if I told you it's impossible to assess your vitamin D status based on current testing practices in both conventional and alternative healthcare? Stay tuned because I'm going to empower you with little known info on myths about vitamin D testing and supplementation, what you need to test that isn't tested to properly assess vitamin D status, what to look for in those labs, and what those labs can tell you about disease risk or hidden disease. Hi, I'm Erica Herman. Join me as I go deep investigating all things holistic health for intelligent people who are sick of BS, all informed by my 2 decades of research, consulting, and even being a best-selling author. The reality is vitamin D testing, your levels, and supplementation are not as simple as mainstream and alternative healthcare have made them out to be. Current practices are reductive, misguided, and 1 to 2 decades behind where they hopefully will be as clinical practice catches up to research and more research is conducted. Currently, it's considered progressive in modern healthcare, conventional and alternative, to test 25-hydroxyvitamin D, or 25-OH-D3, or Calcidiol. If that sounds like Greek or Mandarin, don't worry, just grab your labs from your doctor or your healthcare practitioner, and you'll see your vitamin D is usually listed as 25-OH-D3. But this practice is flawed. Limitations of current vitamin D testing. Vitamin D is typically spoken of in general terms and considered critical for a wide array of bodily functions, including but not limited to gene expression, cell growth, immune system modulation, calcium absorption, for bone health support, alongside other key players like vitamin K2 for calcium transport and deposition. Also, mood regulation, preventing rickets. The list goes on. It's important to understand that even though we call it a vitamin D is technically a corticosteroidal hormone. Like all hormones, vitamin D exists as a pathway along which it is converted. Basically, there are multiple types of vitamin D, with most types being inactive and intermediary. There's more than one critical form of vitamin D. This goes far beyond D2 versus D3. 25-OH-D3 is just the inactive circulating form of vitamin D. Yes, inactive. But that's all modern healthcare tests for. And that inactive circulating form of vitamin D must be converted to the active circulating form, calcitriol, or 1,25-dihydroxyvitamin D3, also known as 1,25-OH-2D or 1,25-OH-2D3, as you can see. It's the ratio between calcidiol and calcitriol, the inactive circulating form, calcidiol, and calcitriol, the active form. It's the ratio between those two that's important. And research indicates is a biomarker or an indicator of health, disease, and/or disease risk. So remember, calcidiol is what your doctor tests for. Calcitriol is what your doctor does not test for. I know those names can get confusing when this is new information. So it's easy to remember that it's the D in calcidiol comes before the T in calcitriol. Calcidiol, calcitriol. And I'll do my best to remind you of the active versus inactive forms as we go. So let's take a look at benefits of calcitriol, the active form that's not tested for. Let's take a look at those benefits and what health complications we see when the ratio of calcidiol, or 25-OH-D3, what your doctor does test for, and calcitriol, the active form your doctor doesn't test for, what happens when that ratio shows that it's not optimally converting. Calcitriol benefits. Calcitriol, the active hormone, is formed from calcidiol, 25-OH-D3, through a process called hydroxylation. That takes place in the kidneys and throughout the body and is regulated by the parathyroid hormone, PTH, and serum calcium. Calcitriol, the active form, it's considered the most active form of vitamin D and has demonstrated activity 100 times higher than that of calcidiol, 25-OH-D3. It is calcitriol that regulates that long list of critical bodily functions and processes described earlier that are attributed just generally to vitamin D, right? Calcium absorption, bone health, overall physiological processes. These are the properties, the benefits of calcitriol, not calcidiol. Also, calcitriol binds to something called the vitamin D receptor, the VDR, inside the cell nucleus. And I'll get to more about VDR later. The real alarm bell is dysregulated conversion. A 1-to-1 ratio of calcidiol to calcitriol is a marker of healthy conversion. Research suggests that low conversion, hypoconversion, or high conversion, hyperconversion of calcidiol to calcitriol, meaning ratios less than or greater than 1-to-1, is associated with disease. Also, in some cases, calcitriol, that active form, can break down too rapidly. Remember that the standard reference range for calcidiol is 20 to 50 nanograms per milliliter, and the functional reference range is 30 to 80 nanograms per milliliter. Conversion from 25-OHD3 to calcitriol, calcidiol to calcitriol, will be in a sweet spot, an ideal ratio of around 1-to-1 when health status is optimal. Not too low of a ratio and not too high, with calcidiol equally converting to calcitriol. There are 3 ways dysfunctional vitamin D conversion can play out. Number 1, you can have healthy calcidiol, 25-OHD3 levels, the inactive vitamin D, but that inactive form is not being converted to calcitriol, active vitamin D. So you have too much 25-OH in relation to calcitriol. You may even be converting the inactive vitamin D, but you wind up with more of another kind of inactive form of vitamin D. Either way, it looks as if you have healthy vitamin D levels on a lab test. And your doctor or practitioner tells you this because that's all that they can see. But you're unknowingly low in active vitamin D in this scenario. This is more common in modern healthcare than is currently realized. The second way dysfunctional vitamin D conversion can play out is, in some cases, you can be adequately converting inactive vitamin D, calcidiol, to active vitamin D, calcitriol, but you break the calcitriol down too rapidly. The third way that dysfunctional vitamin D conversion can play out is, conversely, you have low calcidiol levels, inactive vitamin D, but it's hyperconverting to calcitriol, active vitamin D. So you have too much calcitriol in relation to your calcidiol, that 25-OHD3, the inactive form. So you've got too much of the active, too little of the inactive. In this situation, doctors and practitioners, both conventional and alternative, typically blindly instruct you to take D3 or cholecalciferol supplements because they're only testing your calcidiol levels, your 25-OHD3. So you see how that's misinformed, and you're going to make even more calcitriol that way. You're just funneling things down that pathway of conversion, and your labs just look like they're low in the only kind of lab that's tested for, which you don't need more of that, and that will further burden your body. Check out the following research that covers the importance of testing for and knowing both inactive and active vitamin D levels and the ratio between the two. I'll add links in the video description. This study reveals research about varying ratios of calcitriol active form to calcidiol inactive form for different conditions: hemodialysis, chronic kidney disease, renal transplant, patients with no renal disease, and primary hyperparathyroidism. The study's authors call for testing both biomarkers, right, calcidiol, calcitriol, and assessing their ratio instead of testing for each biomarker separately or only the standard calcidiol. It found ratios differed for different conditions, but it often found hyperconversion. Determination of the ratio is more optimal than the separate evaluation of the two most commonly assayed metabolites. This helpful information could facilitate the elucidation of specific treatment parameters or rational therapeutic choices in different patient populations. This excerpt from a scholarly text highlights the poor conversion rate from calcidiol to calcitriol for those with obesity. So here, increased adipose tissue caused reduction of calcidiol 25-OHD, the inactive vitamin D level, in circulation, and consequently enhance its catabolism, its breakdown in the adipose tissue, converting calcidiol, inactive form, to biologically inactive metabolite 24,25-dihydroxyvitamin D. So here, calcidiol gets converted to another inactive form of vitamin D, not to the active form calcitriol, right? So it can go down a different pathway of conversion. So considering the significance of obesity, which contributes to the onset and progression of autoimmune diseases, the results of interventional studies with vitamin D have been encouraging. So here in this study, this would be an example of hypoconversion, poor conversion for obesity, which makes sense because excess adiposity, fat storage, can inhibit conversion of vitamin D since vitamin D is fat soluble. That same scholarly text also explains how calcitriol can benefit repair mechanisms in patients with autoimmune disease. Calcitriol, the active form of vitamin D, positively modifies endothelial repair mechanisms in patients with autoimmune diseases and dysfunctional endothelial repair mechanisms. Endothelial refers to the inner lining of blood vessels, lymph vessels, and the heart. This scholarly text explains how, generally speaking, adequate conversion of calcidiol to calcitriol can take place, but specifically for those with multiple sclerosis, a type of autoimmune disease, calcidiol is either converted into another inactive form of vitamin D instead of the active calcitriol, or that calcidiol, the inactive form, is broken down too rapidly in the brain. Here it says, and I'm highlighting this here, data suggests that lifelong overexpression of the 24-hydroxylase, so it's an inactive vitamin D metabolite, overexpression of that type of inactive vitamin D and rapid calcitriol degradation in particular human brain regions facilitated brain inflammation and increased MS risk. So again, we're not having that one-to-one conversion of calcidiol to calcitriol. Instead, the calcidiol is converting into another inactive form of vitamin D, or it's converting into calcitriol, but that calcitriol is degrading really rapidly. And that's associated with certain kinds of facilitating brain inflammation and increased multiple sclerosis risk. This study here found that cardiovascular disease risk increases with elevated calcitriol conversion in patients with rheumatoid arthritis, a type of autoimmune disease. So here it says higher calcitriol serum levels, so the active form, and a higher vitamin D hydroxylation efficiency ratio were associated with higher cardiovascular disease risk in rheumatoid arthritis patients. As you can see, conversion of inactive to active vitamin D can play out in multiple ways and is not black or white. I've seen excessive calcidiol to calcitriol conversion in clients' labs that didn't show any indications of elevated calcium levels, which is what some doctors would say, that's what I would look for instead of testing conversion ratios. The doctors, right, who don't test for calcitriol. What I did see was that a lot of chronic health issues like mold illness, heavy metal toxicity, and overall impaired detoxification that mainstream doctors in both conventional and alternative healthcare had not been able to identify and or heal, which is why those clients came to me. I ended up seeing those were the health issues that were associated with these poor or impaired kinds of conversion. Simply put, it's not just poor conversion of inactive to active vitamin D3 that's undesirable, as is the case with obesity. Instead, a high conversion rate of calcidiol, inactive D3, to calcitriol, active D3, is also undesirable, as is too rapid breakdown of calcitriol once it's been converted, as is highlighted in the study about multiple sclerosis. Why does modern healthcare overlook calcitriol? So why isn't testing for calcitriol standard practice in modern healthcare, or at least a suggested practice? Number one, It's the norm, not the exception, that standard practice in modern healthcare lags 1 to 2 decades behind scientific research. Number 2, many doctors and practitioners do not dig deep enough of their own accord. Some doctors may say they look for things like elevated calcium levels, as I've mentioned, meaning the calcium isn't going where it's supposed to go because vitamin D isn't converting well. But that presupposes that low calcitriol is the issue instead of high calcitriol in the case of hyperconversion. Also, there's a lot of other things that can go wrong with insufficient conversion of active vitamin D that your doctor just doesn't screen for. So reason number 3, we need to look at the flawed reasoning of health authorities like the National Institutes of Health, the NIH. The NIH's focus is on calcitriol deficiency instead of calcitriol hyperconversion, or too rapid breakdown of calcitriol. If you go to the NIH website, you can read how calcitriol is not considered a good indicator of vitamin D status because it has a short half-life, a number of hours, compared to calcidiol, which has a half-life of around 2 weeks. And because serum calcitriol levels, right, the active form are, and I'm quoting, tightly regulated by the parathyroid hormone, calcium and phosphate, and levels of calcitriol do not typically decrease until vitamin D deficiency is severe. I'll read that again. Levels of calcitriol do not typically decrease until vitamin D deficiency is severe. End quote. Basically, the NIH is saying you shouldn't test calcitriol to get a read of your vitamin D status. And it's assuming the only concern is low calcitriol, a condition it claims is very rare. This is a reductive logic for 3 reasons. Reason number 1, why the NIH's logic about not testing calcitriol is flawed. It's not that you shouldn't test calcitriol, it's that you shouldn't solely test calcitriol. You should test both calcidiol and calcitriol and look at the conversion rate or ratio between the two. The closer to 1-to-1 that rate is, the stronger the indication your conversion is functioning optimally. Health professionals should be more than curious about understanding this rate because it signals when something deeper is off. So reason number 2 why the NIH's logic about not testing calcitriol is flawed. Even with a shorter half-life, calcitriol will show up in the blood and can be tested. If you take a snapshot of calcidiol and calcitriol levels whenever it is you get your blood drawn, that's valuable information. Because calcitriol will especially be present if your body is converting too much of it, which ties in with reason number 3 why the NIH's logic about not testing calcitriol is flawed. An informed practitioner's concern isn't just low calcitriol, it's too high calcitriol. The NIH only references calcitriol results decreasing when, and I'm quoting now, vitamin D deficiency is severe, end quote. But what if one of the concerns isn't low calcitriol, but too high calcitriol? Or what if the calcitriol is low, but that's masking its rapid breakdown? Basically, the NIH didn't and doesn't fully understand vitamin D pathway dysregulation and has reduced the concern of low calcitriol and has influenced control of the narrative on how to effectively test for dysregulation. In short, we should be testing a lot more than just calcidiol. Current vitamin D testing is a missed opportunity to realize that something deeper is at play so you and your healthcare team can investigate and address the root cause. So why is conversion affected? There are 4 main factors that affect vitamin D conversion, including number 1, lack of exposure to sunlight, specifically UVB rays. Number 2, lack of cholesterol, more specifically, LDL cholesterol. Vitamin D requires cholesterol for production. And newsflash, cholesterol is required for the synthesis of all kinds of hormones. Both vitamin D2, which is found in plant foods or supplements, and D3, found in animal foods or supplements, must be made, okay? Again, this is the supplemental form, that form we're talking about. This is different than the calcidiol and calcitriol. So vitamin D2 in plant foods or supplements and D3 that's found in animal foods or supplements, it must be made by a photochemical reaction between UVB light, found in sunlight, and 7-dehydrocholesterol for D3 and ergosterol for D2. For us humans and some animals, this process takes place in the skin. And yes, that dreaded UVB light and cholesterol are actually healthy and critical for the vitamin D pathway. Recognizing vitamin D's hormonal nature challenges conventional and limited views of this alleged vitamin and highlights the intricate interplay between sunlight, cholesterol, and this multifaceted regulator of health. Number 3 of why conversion is affected: lack of sulfur or sulfate, often seen in poor glutathione status. However, far lesser known than vitamin D's production requirement of sunlight and cholesterol is a lesser known and therefore lesser discussed requirement of vitamin D: sulfur. Sulfur is required directly and or indirectly for vitamin D production, depending on which type of vitamin D we're talking about. Unfortunately, in the 21st century, too many of us avoid the sun, think cholesterol is evil, and don't consume much sulfur because our water is softened and stripped down, and most people are scared of eating egg yolks, which are not only some of the richest sources of sulfur, but cholesterol as well. And even if we consume enough sulfur, we can also have problems with the way our body processes sulfur. Reason number 4 for poor conversion: activation of the cell danger response, or the CDR, and derangement of the vitamin D receptor, or VDR, which is a response to various stressors. Dysfunction of vitamin D conversion can result when your body and your cells are under threat or under perceived threat, and the cell danger response, the CDR, and the vitamin D receptor, VDR, get out of whack. The cell danger response is a biological mechanism I often liken to a castle's defense system. I came up with this analogy years ago and feel like a proud nerd whenever I get to use it. In this analogy, when your body, specifically your limbic system, it's part of the nervous system, when it perceives danger, real or imagined or perceived, it raises its metaphorical drawbridge, restricting nutrient intake and detoxification processes into and out of your cells. In this state, cellular resources prioritize defense over normal functions. Dr. Robert Naviaux pioneered CDR, cell danger response research, elucidating its role in chronic illness, and he proposed that various stressors, be they physical, psychological, or environmental, trigger the cell danger response, leading to a protective but dysfunctional response. And this defensive stance, similar to a castle under siege, can persist even after the perceived threat diminishes, contributing to chronic conditions. Understanding the cell danger response provides insights into complex illnesses and offers potential avenues for health interventions. The vitamin D receptor is a protein present in cells that acts as a molecular sensor for vitamin D. Calcitriol, that active form of vitamin D3, not calcidiol, is what binds to and activates the nuclear vitamin D receptor. When it's activated, the vitamin D receptor forms a complex that regulates the expression of genes that are critical for various physiological functions. This includes calcium absorption, immune system modulation, and cellular growth. The VDR plays a pivotal role in translating the biological effects of vitamin D into cellular responses, influencing overall health and well-being. Clinically, I've had clients with an array of chronic issues like mold illness, heavy metal toxicity, autoimmunity, impaired detoxification, gut issues, pain syndromes, the list goes on. They would appear as if they had either low 25-OH-D3, right, what your doctor tests for, or that they had healthy 25-OH-D3. But their calcitriol levels, when those were tested, were much higher in relation to that 25-OHD3. Again, that would not be something that most practitioners are aware of because they're not usually testing calcitriol, right? But on the surface, it looks like those levels are healthy, or it looks like maybe they're low, right? The inactive form is low. This is the cell danger response in action and deranging the vitamin D receptor. So here's a distillation of the three main points of what all this talk about the cell danger response and the vitamin D receptor means. Number one, vitamin D deficiency, calcidiol, or 25-OHD3, isn't the cause, it's the symptom. Vitamin D deficiency, what is tested for in a typical medical office, is not the cause, it's the symptom. Number two, knowing your calcidiol 25-OHD3 levels is not helpful without more comprehensive vitamin D pathway testing. Number three, trying to correct the 25-OHD3 lab numbers by supplementing with D3 or cholecalciferol is a misinformed, reductive, and biologically burdensome practice made by many doctors and practitioners in both conventional and alternative healthcare. Before we talk about supplementation, I want to mention one more active form of vitamin D, vitamin D3 sulfate. This critical form of vitamin D3 receives little attention, even though its benefits are likely far wider than what existing research suggests. One of its amazing benefits is protection from radiation of all kinds, including radiation from the sun. Although some research has been conducted on vitamin D3 sulfate, at this time we can't really test for it, though as its name indicates, it requires sulfur, and less obvious, it also requires cholesterol. Ideally, proper assessment of vitamin D status would take into account this other active form of vitamin D. But back to vitamin D3 calcidiol, calcitriol, what we can test for, right, and supplementation. Vitamin D supplementation based on current testing is unreliable and misinformed. Now that you understand it's not a given that your body converts inactive vitamin D to active vitamin D at a healthy rate, you can also understand why only testing your 25-OHD3 or calcidiol levels is unreliable and narrowly focused. Also, when you realize dysregulation of calcidiol to calcitriol conversion is a symptom and not a cause, and the cell danger response is at play, and lab tests only test one variety of vitamin D, an inactive kind, you have to ask yourself if D3 supplements are helpful or wise or possibly burdening your body. Your body can self-regulate calcidiol production through sunlight exposure on your skin, but you can't do that with supplements. Vitamin D3 supplementation, even if it may increase calcidiol levels, and you can see that increase in lab results, is absolutely not an indicator of whether or not you are converting inactive D to active D at a healthy rate. And neither calcidiol nor calcitriol levels indicate what your vitamin D3 status is. See, when a person who's hyperconverting calcidiol to calcitriol, inactive to active, when that person takes vitamin D supplements, they deplete themselves of sulfur or sulfate, which is already commonly deficient in our day and age. And they tax their glutathione levels, the master antioxidant, which contains sulfur, and that's already typically depleted in people with chronic conditions that are associated with hyperconversion. Simply put, vitamin D supplementation is not right for everyone, especially doses of multiple thousand international units IUs per day. In more cases than is currently realized, supplementation is poorly informed, misses the point, and can create more problems. Also, beyond vitamin D pathway conversion, there are a number of other effects that vitamin D supplementation can have on dysregulating other nutrients. For example, lowering vitamin A and indirectly spiking copper, which is not a good thing for many people in this day and age. This happens due to vitamin D pulling calcium from circulation into tissues and calcium having an inverse relationship with potassium and lowering intracellular potassium, which itself increases copper and copper toxicity, retention, or kind of copper retention. And that's already a thing, an overlooked thing in this day and age. I want to note something important, and I'll say this because this question always comes up. This has nothing to do with supplementing vitamin K in addition to vitamin D. Also, what I'm saying pertains to vitamin D supplements only, not vitamin D that your body makes from sun exposure, the latter of which your body can regulate. In my own clinical work, I also look at tissue mineral status alongside calcidiol and calcitriol rates to assess need for supplemental vitamin D, because for so many people, supplemental vitamin D is misguided and overused. Supplement recommendations should also extend beyond simply popping pills to optimize the following. 1, sun exposure. During winter months, or if you live at higher latitudes, informed use of a UV light is helpful. 2, cholesterol levels. Not too low and ideally assessed with more nuanced panels than standard lipid panels are capable of. Instead of standard lipid panels, you can look to what's called a VAP, a vertical auto profile, or an NMR, nuclear magnetic resonance cholesterol tests. If you're interested in running one of those on yourself, check out the link in my description. They're great because they get really granular and they can look at things that standard cholesterol tests just can't. Also, sulfur consumption is really important. This includes egg yolks, raw milk, and certain vegetables. But egg yolks are highest in sulfur and are delivered alongside the cholesterol needed for vitamin D synthesis. Also, glutathione status, like I mentioned earlier. Glutathione contains sulfur and it's considered the master antioxidant. If you're interested in running a test to assess your glutathione status, check out the link in my description. What does all of this mean? Ultimately, knowing the ratio of calcidiol, what most practitioners test for, and calcitriol, what few practitioners test for, let alone look at in proportion to calcidiol, is an empowering early-stage biomarker that can tell you if deeper dysregulation is going on. What gets my goat is that this testing is not expensive, and it's such a missed opportunity. Now you don't have to miss that opportunity. No more slipping through the cracks of modern healthcare, both conventional and alternative. If you like this video on myths about vitamin D testing, check out my video, 5 lab problems your doctor may not know, for more problems with lab testing in both conventional and alternative healthcare.